stars of nuclear medicine in the Middle East, like very good representative for Arabic scientists. So you can start now, and we will continue with discussion after finishing this talk.
جزيل الشكر دكتور خالد على هاي المقدمة الطيبة. هذا من طيب أصلكم ومن أخلاقكم، واللي بيعكس أصالة الإخوان المصريين. وطبعا نبدأ بالسلام عليكم ومساء الخير. وببدأ كمان I would like to thank the Egyptian Society of Nuclear Medicine Specialists for this kind invitation to discuss this new and important topic about FAPI PET-CT scan. And actually, I would say that FAPI is one of the most exciting innovations in the field of nuclear medicine in the last 2 decades. However, with each innovation and each breakthrough, it brings its challenges. However, these challenges, sometimes, if tackled wisely, may itself represent an opportunity to expand our applications and to expand sometimes far beyond oncology imaging, and to monitor another non-malignant diseases, and also to expand far beyond diagnostic toward theranostic. And this is what I will share with you during this presentation about challenges when we interpret FAPI PET-CT scan and the potential toward theranostic, as well as the potential applications of FAPI PET-CT scan beyond oncology. These are the outlines. First, I will shed light on the mechanism and basic sciences of FAPI, and why do we see FAPI uptake and what we are imaging exactly, and then to identify the normal variant and to compare the FAPI biodistribution to FDG, and also to compare FAPI and FDG in common tumors, to share our real-world experience from Jordan and KRCC about the value of this new probe, and also the perils and pitfalls that have been identified during our practice, and to elaborate on this non-oncologic uptake and to see where we can utilize it, and insights on FAPI radioligand theranostic, and sharing with you some of our publications on this regard. So after a decade of relying on FDG PET, FAPI has emerged as a true game changer in the pan-tumor imaging. And it has been advocated that it may represent the molecule of the century. And this is due to two facts. The first, that it is a pan-tumor, and it is the first pan-tumor after FDG. And the second most important, that it has a theranostic potential. So all the tumors that can be imaged by FAPI may at some time point of we optimize the radiopharmacy for this probe, we can deliver theranostic and the treatment, radioligand therapy treatment, to the sites of the disease. However, in my editorial to the World Journal of Nuclear Medicine, and I emphasized the importance of recognition, the non-malignant uptake, as we have encountered many non-malignant uptake during our practice for the last 3 years, and we reported many in certain publications. However, as I mentioned before, this non-oncologic uptake and this benign uptake may itself represent an opportunity to monitor certain disease, to diagnose certain disease, and to follow up such non-malignant diseases. So it is important to understand what is FAPI and what we image exactly in PET-CT scan. So as you know, when we talk about FDG, it is about the glucose metabolism. When we talk about PSMA, it is certain prostate-specific membrane antigen. The same story for somatostatin receptors in neuroendocrine tumor. However, in FAPI, actually, we don't image the tumor cells itself. We image the matrix, the extracellular matrix, and the micro environment of the tumor. And actually, the microenvironment of the tumor and the matrix represent more than 90% of the cancer mass or the malignant tumor mass. And for this, what we see exactly, it is the cancer-associated fibroblast, which has certain receptors for the FAB, fibroblast activation protein, and it is here when we talk about FABI, it is alpha. And there are many pro-inflammatory and many stimulators actually to enhance this uptake. So in general, there now we have certain molecules. We started, most centers worldwide started with the molecule FABI04, which can be labeled with gallium. After that, with minor modifications in the chemistry, we came up with the FABI46, which has a somehow better distribution and better tumor to background ratio. And also this one can be labeled with gallium. And also the FABI74 can be labeled with fluorine 18. And in the last 5 years, we have seen many publications about another promising molecule. It is FABI2286, and this one can be used both diagnostic, but also can be used as a theranostic for radioligand therapy when it is labeled with lutetium-177 or Y90, or also alpha emitters like actinium. So we talked about the mechanism of uptake in malignancy and in cancer. But in this lecture, as I promised in the beginning, we will discuss the non-malignant uptake. And here the main thing comes to our mind is the inflammation and the reactive. And it is a very complicated process at the cellular and at the submolecule level. However, it is all about changing the status of the normal fibroblast, which is present in most tissue of the body, to activated fibroblast. And this is what we can image by PET-CT scan. And this is seen, for example, in inflammation, in certain infection, in remodeling, wound healing. All of these would enhance this change from a quiescent or a quiet state of active inflammation of fibroblast to the activated fibroblast. And this is when we talk about only activated fibroblast, this is the non-malignant. When we talk about the malignancy, we talk about the cancer-associated fibroblast, a certain type of the fibroblast, which is usually in cancer. And in our publications in Seminar of Clinical Medicine, we elaborated on this mechanism. So it also worth mentioning here that when we talked about the uptake of FABI in the microenvironment of the tumor and the extracellular matrix, but also there are certain tumors like sarcoma. The malignant cell itself will show increased FAB uptake, and also those tumors are the most potential one for theranostic because the uptake will be very prominent. It comes from the localization and fixation and in the matrix and in the tumor microenvironment, but also in the tumor cell itself. One good example is the solitary fibrous tumor, where the uptake of FABI will be very prominent, and there are promising data about theranostic in this tumor. And also it is important to understand that biodistribution of FABI. It is very easy. Actually, because there is no physiologic uptake in the normal organ, very minimal. As you can see from this MIB image, no activity in the brain, no activity in the heart, no activity in the bowel and in the abdomen. Only mild, this FABI radiotracer will be excreted in the urinary system. So we can see the pelvic cell systems and the activity in the urinary bladder, low uptake in the uterus. However, there are other types, like, for example, the fluorine FABI 74, the excretion will be through the hepatobiliary system. So it is important to have a good scientific knowledge of the radiotracer and the molecule that we use. And also there are normal variants. Also, these are among the normal variant. Sometimes we may see some mild activity in the thyroid gland, in the salivary gland. The pancreatic islet cells also may show increased FAPI uptake, and this is very important because FAPI commonly used to evaluate pancreatic adenocarcinoma, where usually the performance of FDG PET-CT scan is suboptimal. And also, in the uterine, we can see sometimes intense uptake and without any changes or without any masses appreciated on CT part of the study. So these are another normal variant, and I will elaborate on these patterns during coming slides. Also, when we start working with a new radio tracer, it is important to understand the practice and the procedure aspect of this radio tracer. And FAPI is very welcomed as a easy to use radio tracer in PET-CT scan. Why? For example, when we talked about FDG, which is used in more than 90% of PET-CT scan performed worldwide, we usually request patients to be fasting at least 4 to 6 hours. In FAPI, this is not requested. The only thing that we request from patients is to be well hydrated, to have about 1 liter of water before in the few hours before the exam, because as I mentioned, most of gallium-based FAPI are excreted through the kidneys, and this will reduce the non-desired radiation dose to the urinary system and to the bladder, and also will help in increasing the tumor to background ratio if we are evaluating something close to the kidneys or in the pelvis. For example, when we talk about FDG, we instruct patient to schedule or stop insulin. We sometimes stop the steroids, and if we evaluate certain lesions in the abdomen, also we request to stop metformin. This is not needed in FAPI PET-CT scan. Also, there is no competitive inhibition about the glucose metabolism, so there is no need to check the fasting blood sugar. The dose, as other gallium-based radioisotope, usually it will be about 50% of the dose injected. In case of FDG PET-CT scan, it is around 100 to 200 megabecquerel for exam, or 1.5 up to 2 megabecquerels per kg, according to the resolution and the sensitivity of the PET scanner that you have in your center. Another important feature that is very important for logistic for nuclear medicine department, that we can start FAPI PET-CT imaging about 10 to 15 minutes after injection. And this is very welcome by patients and very convenient. However, I still recommend to have either dual time points or to have imaging around 30 to 60 minutes to optimize the tumor to background ratio. Now we have an ongoing research at KRCC to evaluate the added value of doing a dual time point, or if there is a need to have the delayed image. I am optimistic that we will publish our data in the second quarter of this year, and we will share our experience with the nuclear medicine community worldwide. The most important feature of this radioisotope that it has a theranostic application. FAPI can be labeled, as I mentioned, with therapeutic radioisotopes like lutetium, like actinium, like terbium, and use it for treatment of certain tumors. And there are many ongoing research on this regard. Now, as I mentioned, if we compare FDG to FAPI, there is no background activity in the brain, in the liver, in the bowel, and this would improve the target to background. As you can see from the demonstration and the bar graph in your left hand, in most normal organ, the activity of FAPI compared to FDG is significantly less. The only sites where FAPI uptake is higher than FDG is the tumor itself, and also the metastatic deposits, as we can see from this important work from Heidelberg group, which who hold the patency for the FAPI, Professor Giesel and his group. Also, another important publication from the same group, in this analysis, they showed that most common tumors have significant FAPI uptake, with SUV max exceeding 10 in most common tumors. For example, like carcinoma of unknown primary, sarcomas, esophageal cancer, cholangiocarcinoma, breast, lung, pancreatic. All of these, they have significant increased FAPI uptake, usually above 10, and this will be very intense compared to FDG PET-CT scan. So, however, we have to keep in our mind there are still certain tumors, the performance of FDG or the FDG uptake is much better than FAPI. Most important, I would mention here, the lymphoma, multiple myeloma, seminomas, among other tumors, which usually do not demonstrate desmoplastic reaction. This is one of the most important features to show intense FAPI uptake, the desmoplastic reaction, which is usually common in epithelial tumors. However, like the tumors that I mentioned, usually FAPI uptake will be much less compared to FDG PET-CT, like lymphoma and multiple myeloma, among other few tumors previously mentioned. This is another important work coming from China this time. And here I would like to mention that China is leading the world in the research related to FAPI in both diagnostic and therapeutic. Most of data regarding therapeutic application of FAPI came initially from China and India and also Germany. Nowadays, other parts of the world like US and Australia started to generate and publish some trials about the value of FAPI in therapy. As you can see from these images, the upper row is FDG and the lower row is FAPI. In most these common tumors, the tumor delineation and extent is much better appreciated by FAPI compared to FDG PET-CT scan. However, in certain tumors, like for example, the gastric cancer, in this case, you can see the tumor is only appreciated on FAPI PET-CT scan. For example, in pancreatic cancer, like in this case, the tumor extends locally as well as the metastatic deposits only appreciated by FAPI, and these metastatic deposits were not depicted by FDG PET-CT scan. The same scenario for local lymph node infiltration in case of colorectal, only appreciated on FAPI, not appreciated on the FDG. In case of ovarian, also there are many metastases, especially this of peritoneal carcinomatosis, only appreciated on the FAPI and barely seen by FDG PET-CT scan. In other tumors, FAPI delineates the tumor extent better than FDG PET-CT scan. At KRCC in Jordan, at King Hussein Cancer Center, we started practicing FAPI late in 2022. And we published our initial experience January last year. Now 2025 is last year. And in this paper, we analyzed the first 77 FAPI PET-CT scan performed in 48 patients. The most common types that were included in this cohort were upper GI tumor, gastrointestinal, pancreatobiliary, and also some head and neck cancers. And this is about the collaboration with referring physician, who we managed to convince them about the value of this new tracer, and we managed to generate some good data. There was a strong correlation between FAPI uptake and the tumor grade, especially in those patients who were therapy naive. And also the tumor to background was very high, and it was the highest in the pancreatobiliary cancer. Actually, in our cohort, management was changed in 1/3 of our patients based on FAPI PET-CT scan. All those patients have both FAPI and FDG. And when we measured this percentage, this was the added value of FAPI, where FAPI itself, or per se, but change the management plan, not FDG PET-CT scan. So also one important feature of our cohort that FAPI managed to depict certain metastatic pattern like peritoneal carcinomatosis, small nodal involvement, and also small liver metastases that were missed by FDG PET-CT scan. I will share with you now some of our patients who also we published those patients. This was the image of the month in the European Journal of Nuclear Medicine, a case of medullary thyroid cancer. And usually we do FDG and DOTA PET-CT scan for medullary thyroid cancer. As you can see from the level of the thyrocalcitonin and the CAA very high, so and metastatic deposits actually were suspected. DOTA PET-CT scan did not show actually obvious metastatic involvement. And let us look together to the FAPI PET-CT scan. Extensive mediastinal FAPI avid metastasis, extensive liver metastasis, and this explains why we have this very high level of thyrocalcitonin in this case. Another case, also we published this one in the Clinical Nuclear Medicine. This patient was suspected to have hilar cholangiocarcinoma, what we call Klatskin tumor. FDG PET-CT scan is the standard of care, was done initially, and did not show any abnormal or any hypermetabolic lesion in the liver hilum, despite the fact that EUS and other imaging modalities, there was a suspected mass in addition to the clinical representation of the patient. So this case was discussed in the multidisciplinary clinic, and nuclear medicine physician suggested to proceed with FAPI. As you can see, this was the second case published in literature about the value of FAPI PET-CT in hilar cholangiocarcinoma. Nicely depicted, very intense FAPI uptake, which represented the tumor that was proven by histopathology later on to be hilar cholangiocarcinoma. And this is the story that we have seen in many cases in different tumor like gastric, in few breast cancer patients, but most commonly in our practice, it was in the upper GI tumors and pancreatic adenocarcinoma. We have encountered many scenarios like this where FAPI PET-CT scan performance was better than FDG PET-CT scan. However, during our practice, we have seen and described many non-malignant uptake that actually wasn't well described in literature, because we were among the first centers worldwide also to use it for in the clinical and to generate what we call real world data about these non-specific uptake. In our practice, in our cohort, this was encountered in 88% of our scans. We identified 220 pitfalls when we analyzed our data for this specific purpose. Most commonly, it was encountered in the musculoskeletal, like osteoarthritic and musculoskeletal overactivity, in the also certain benign lesions like leiomyoma, prostate benign hypertrophy, and also most scars, both surgical or iatrogenic procedures, and also in the certain, like in the lung, for example, pneumonia or any infectious process, pacemakers, and also, for example, we were the first group to describe the axillary fold or the arbit as non-specific uptake. What are the implications of this uptake in benign and fibrotic inflammatory condition that should be recognized and not to interpret them as malignancy or not to recommend further evaluation to exclude malignancy, but should be recognized as non-malignant uptake. And these should be interpreted in a proper clinical context and in correlation with other investigations and the expected pattern of the disease to avoid overdiagnosis. And we conclude from our first paper that FAPI PET-CT offers promising diagnostic and staging values in certain tumor, in particular where FDG PET-CT scan performance is suboptimal. And this is, as I mentioned, in the tumor with epithelial tumor and fibrotic tumor, where we have a strong desmoplastic reaction, but also interpretation of FAPI requires caution, and we have to be cautious when we do interpretation to avoid very common benign uptakes and not to overdiagnose or to describe as malignant. This is another work we identified from literature also about the non-malignant uptake. This is one example from our original paper, and in this paper, in this case, we described the uptake in the armpit as non-specific uptake in the axillary folds, also in the benign prostatic hypertrophy, and also in certain joints due to osteoarthritic changes. Another case from our cohort, and this was published as in the clinical nuclear medicine also. We were the first group to describe the anorectal sphincter, and also uterine fibroid have been described previously. Also, in this case, we demonstrated the intense uptake in the uterine fibroid, and also some reactive muscular activity and very articular inflammatory changes. We can see these focal uptake as non-specific uptake. Sometimes the situation is challenging and needs meticulous assessment. This is one example from our cases, and this was a case of pancreatic head cancer, and first FDG PET-CT scan was done and demonstrated the uptake. It was, I would describe it as mild to moderate only uptake in the pancreatic head tumor. So we suggested that we need to do further assessment to exclude metastatic deposits by doing FAPI PET-CT scan. In addition to the fact that patient at that time had a clinical presentation of jaundice, among other. Okay. So when we did the FAPI PET-CT scan, as you can see, regarding the primary tumor, there were intense FAPI uptakes in the pancreatic head tumor, but also in this case, we encountered this mosaic pattern in the liver, multiple FAPI uptake foci, in addition to diffuse uptake in the pancreatic body and the pancreatic tail. When we correlated this with other laboratory findings and the clinical presentation, this was, and the fact that FDG was negative, as well as other imaging modality, this was due to cholangitis, and when patient was treated, these uptake were resolved. Another also very common procedure done for pancreatic tumor, and as I mentioned, we have done FAPI in many pancreatic adenocarcinoma cases, is the stent induced to the tumor to relieve the jaundice and the obstruction in the biliary tract. And as we have seen in many cases, this would induce non-specific uptake after FAPI uptake after the stent introduction or placing in this tumor. Also, as you know, sometimes we do embolization for certain vessels, like for the example, the gastroduodenal artery, and also this procedure would result in non-specific uptake, and this should be interpreted cautiously, not over-diagnosed as malignant or suspicious uptake. Actually, in this original work from University of California, they analyzed FAPI uptake after invasive procedure, and they found that it is encountered in more than 15% with average SUV of more than 3. And they also correlated the FAPI patterns and uptake with the introduction of foreign body. So in cases where there was no foreign body, most of these non-specific uptake resolved within the first 8 months. But in cases where foreign body was introduced, this uptake persisted more than 8 months in these scenarios. Also, another common non-specific uptake is the FAPI uptake in the breast and the uterus. And this is actually age dependent and hormonal status dependent. So it is important to be careful when we do such interpretation. And sometimes also patients breast cancer patients who started hormonal treatment may develop such non-specific uptake, and this should be recognized as only related to hormonal status rather than suspicious or concerning uptake. Most interventional or most heterogenic procedures, like for example, pacemaker placement and some traumas like rib fractures or any trauma, also may induce non-specific FAPI uptake, as we can see from this case in the pacemaker as well as in the non-specific uptake in the rib fracture. This is the paper I told you about. This is a very good review of literature about the non-specific FAPI uptake, most commonly encountered in atherosclerosis, but also musculoskeletal related to degenerative changes, any maybe procedure like dental issues, thyroiditis, or other inflammatory conditions. Also benign inflammation like hemorrhoids or sometimes liver fibrosis, among others, also may induce non-specific FAPI uptake, in addition to the certain infectious process like esophagitis, pneumonia, and glotitis may all induce non-specific FAPI uptake. This is a case of vascular uptake, and in this case, the authors have demonstrated the difference between FAPI and FDG. The FAPI uptake in the vessels is much more prominent compared to FDG PET-CT scan, as you can see from this case. And also other benign tumor, like in this case, tenosynovial giant cell tumor, but also other benign tumors like fibroma, schwannomas, angiomyolipoma, pulmonary solitary fibrous tumor. All of these have been described in literature as demonstrating intense FAPI uptake, but these are non-malignant, and we should correlate the features coming from bit part along with the feature coming from CT, or to correlate that with the MRI or other imaging modality to reach a correct diagnosis and not to overdiagnose or to just make confusion for the referring physician. Actually, we started this work looking about ongoing clinical trials investigating the role of FAPI in non-malignant uptake. And as you can see, this search and this analysis, this search was done maybe in June 2025. At that time, there were 47 pending clinical trials looking at the value of FAPI PET-CT scan in benign tumors and benign diseases, like for example, liver fibrosis, cirrhosis, cholangitis, some maybe pancreatitis, and inflammatory bowel disease, among others. So there are many ongoing works in this regard, and in the coming slides, I will share with you why these works and why these investigations are being done. For example, this is a case of arthritis, and as we can see, as we always say that image speaks louder than words. The uptake on the FDG is very minimal on the inflamed joint. When we look at FAPI, it is very intense uptake in all inflamed joint, as you can see in the upper limbs and in the lower limbs. And in this work, they correlated the biomarkers with the level of FAPI uptake. And also they found that patients, after being treated, and when the titers decreased, the level of FAPI uptake also decreased accordingly. So we can monitor the treatment of arthritis and inflammatory joint disease by FAPI PET-CT scan. Another important aspect where FAPI can be utilized in non-malignant diseases is fibrosis. And when we talk about fibrosis, we talk about liver fibrosis, lung fibrosis, myocardial fibrosis, a very serious diseases in certain scenario. In this work, they showed that the grade of fibrosis correlates significantly with the level of FAPI uptake, and also those patients who were treated and responded, there was a decline in the level of FAPI uptake. with significant statistical difference. The same regarding idiopathic pulmonary fibrosis. Also, there is strong correlation between the status and the activity of the disease and the FAPI uptake. So this is now we finish the the part related to the benign uptake and how we can utilize FAPI imaging in the monitoring and in staging of non-malignant diseases. Regarding FAPI theranostic, as I mentioned, one of the most important features of FAPI compared to FDG that it has a theranostic potential. That means that we can label the FAPI, and the most common one now is the FAPI molecule 2286 with another molecule used in Germany by Professor Richard Baum. It is very similar to 2286. It is the PP183, I guess, but maybe the number is, I am not 100% sure about. And this, for example, in this review we published in Seminars of Nuclear Medicine, we look about the emerging horizon and the clinical promise in solid tumors about the potential of lutetium FAPI radioligand therapy. And as you can see from this timeline of FAPI, optimization of FAPI PET-CT scan development, we may say that 2018 it was a landmark for the FAPI PET-CT scan. Regarding radioligand therapy, there was it was in 2021. So worldwide experience is still very short and very young. And actually, FAPI theranostic is highly expressed in more than 90% of the epithelial tumor, as mentioned in the beginning, and this making it a prime theranostic target. Unlike a traditional approach focusing on cancer cells only, here we can target the matrix and the tumor microenvironment, and this can be combined with other treatment. So FAPI theranostic disrupt the supportive tumor stroma, and when we talk about stroma, it is vital and critical for metastasizing and for growth of the tumor and for survival of the tumor cells. So when we target this stroma with FAPI radioligand therapy, we help other maybe more specific immunotherapy or targeted treatment like the TKIs, among other. We target in FAPI theranostic the stroma, and this will be a complementing the cell-directed therapies. And this is a promise for and an avenue to improve the anti-cancer treatment in the early future. If I am maybe I am optimistic about to see these applications in pancreatic cancer and for example in hepatobiliary cancer and breast cancer, especially for those patients who exhausted other treatment options and left without any other treatment options. I believe that we will see in the coming few years, we started to see some good cases and some good responses, but we will see more in literature and we will see more experiences about the value of FAPI radioligand therapy in those cases in the early future. Also, the most important in our analysis and in our review is the safety profile of the FAPI radioligand therapy. Actually, hematological toxicity were seen only in 10% of cases, with minimal or hepatic toxicity reported, usually grade 1 or grade 2, and grade 3 and grade 4 regarding renal toxicity or liver toxicity almost were not reported. Grade 3 was reported in hematological toxicity, which is seen in other treatment modalities like chemotherapy or immunotherapy, among others. As I mentioned in the beginning, most of the work, according to our analysis in this review, regarding the potential of FAPI radioligand therapy came initially from China. And however, nowadays it is expanding to include other parts of the world. Also, in this in our publication in Theranostic, we looked about lutetium in solid tumor. In this one, we looked at as comprehensive therapeutic potential of FAPI RLT in all tumors. And we did in this case a systematic review to look at the disease control rate, which was variable from around 20% to 83%. In this analysis, we included 27 studies with 144 patients. Again, only less than 10% encountered grade 3 and grade 4 toxicity. So again, the safety profile of this radioligand theranostic approach with FAPI is very promising. However, we know that we still have challenges and there are many things that we need to improve. First of all is the rapid tumor washout, which limits the dose delivery of FAPI radioligand therapy. In one analysis published by Professor Richard Baum, he mentioned that each cycle would deliver around 3 to 5 gray to the metastatic or tumor sites, which is, in my personal view, is not enough. We need to increase the residual time, the tumor residual time, to optimize this treatment. And there are many radiochemists and radiopharmacists worldwide working in the engineering of the molecules to address this issue. And also, I believe, as I mentioned, that we have an avenue to improve the patient's outcome if we manage to combine the treatment, like, for example, FAPI radioligand therapy with certain chemotherapy or immunotherapy to improve the outcome of those patients, especially those who exhausted other treatment options and left without any hope. Also, this is about, we published this is specifically about sarcoma because, as we mentioned, sarcoma, I believe it will be one of the first tumors that will be sufficiently targeted by FAPI radioligand therapy. And also, we showed the safety profile of this radioligand therapy and the good disease control rate in those tumors. So we can conclude that FAPI PET-CT now is an emerging pan-tumor molecular probe with a strong diagnostic and with a strong therapeutic diagnostic potential, in particular for those tumors where the performance of FDG PET-CT scan is not optimal. And here we talk about, for example, like pancreatic cancer, like certain types of breast cancer, like cholangiocarcinoma. Other types, we know that the performance, ovarian cancer, for example, that the performance of FDG PET-CT scan is suboptimal. And we know for a fact now that FAPI performance is better than FDG. So I believe that there will be a very prominent role for FAPI in the coming few years. However, initially it was thought that this new probe is a tumor specific, but as we have seen during this presentation from different work from different aspects of the world, there are multiple non-malignant uptake. We can, in brackets, call it pitfalls if we are doing the FAPI PET-CT scan for cancer imaging. However, this non-malignant uptake itself represents another avenue where FAPI PET-CT scan can be utilized to monitor benign diseases, like we talked about fibrosis in the liver or in renal or in heart, also about certain diseases like arthritis. I believe that there will be a good value of this radio tracer. However, the most important when we talk about FAPI theranostic, it is a huge potential currently under investigation in multiple centers worldwide. However, large-scale, multi-center trial, phase 2 and phase 3, which are, if possible, to be randomized, are essential to refine the clinical practice and transform patient care utilizing this new, very promising molecule in the world of nuclear medicine. And by this, I would like to thank you for your listening, and I am happy to answer any question you may have. وشكرا للجميع ويعطيكم العافية.
Thank you very much, Dr. Akram. It was a very nice presentation with elegant images. مي جالك أسئلة؟
أيوة we have received a question and Dr. Muhammad Abdelrazak wants to ask by himself. We may start with a question by Dr. Noor. She asked, or he asked, I don't know, can FAPI to be considered as non-specific tumor imaging tracer because of heterogeneity of FDG in distinguishing benign or malignant tumor?
Now, as I mentioned, FAPI is very promising molecule and the probe for malignancy. However, there are many non-oncologic uptake of FAPI, and this should be recognized. However, if this interpreted in the proper context of the disease, we can differentiate which uptake is related to the malignancy or the tumor itself, and which uptake is related to non-malignant uptake. This is the same story in FDG PET-CT scan. However, the experience with FDG PET-CT scan now, it has been for the last 7 decades, at least for the last 4 decades. And when we talk about PET-CT, we talk about maybe since more than 25 years now. All PET scanners in the world are PET-CT scan. Our FDG for oncology started late in 70s, and the experience is very wide, and most guidelines internationally based on FDG PET-CT scan. Now FAPI is as we say, new player in the deck, and we need to show the value. We need, as I mentioned last slide, to conduct randomized or multi-center clinical trials to show the value of this new tracer. However, it has started to show added value, and it has started to replace FDG PET-CT scan in certain scenarios. And I am aware of some centers, they will inject both FAPI and FDG, utilizing the fact that FAPI can be imaged as soon as 15 minutes after injection, and then they can do the FDG PET-CT scan at 1 hour after FAPI. And this is definitely under certain IRB and certain clinical trials. However, it will be beneficial for the patient at the end, and this practice is increasing. So I believe there is an added value for FAPI PET-CT scan as a bony tumor, in addition to the fact that it has a great theranostic potential.
Thank you very
شكرا
much.
دكتورة مي، اللي عايز بس حضرتك تسمحي يفتحوا المايك
دكتور
unmute.
حاضر
حاضر.
حاضر يا خالد.
ممكن نفتح المايك لدكتور محمد عبد الرازق؟
ايوه. السلام عليكم.
وعليكم السلام.
First of all, I would like to welcome Professor Akram. He is really a great figure for us all, Arab community of nuclear medicine, and I appreciate.
متشرفين دكتور. شكرا.
الله يحفظك. We appreciate, of course, this comprehensive talk or presentation. I have actually some concern about the differences in grade of uptake according to the FAPI compounds.
Yes.
As you mentioned, those applied in Theranostics, and you specified actually the compound used by Professor Baum, yes, from 2 to 5 gray per gigabecquerel, of course, right?
Okay.
And this is ligand peptidic one, but actually you have albumin binding one like EB, for example, it can deliver up to 8.
Yes.
Also monomeric deliver low, dimeric higher slightly, like that. Anyhow, my question now, how to match these compounds and the delivering dose with the number of sessions in order to optimize this response, in particularly in many studies like Professor Baum also and Saadi, like that, they showed either partial or even progressive disease with their used compounds. How can you modulate this? Thank you very much.
Thank you very much for this important question, and I totally agree with you. that there is a need for optimization. And actually, will be only answered when we conduct multi-center randomized, or at least multi-center clinical trial with a specific protocol. In such a protocol, we will do multiple time imaging to make sure there is sufficient tumor residual time before starting treating those patients, and also to do some dosimetry to make sure how many grays we can deliver for those patients and for those metastatic deposits and for those tumors when we do such dosimetry. This is how we can optimize the FAPI radioligand therapy. And actually, it is the same story. If we go back and look at the history of PSMA radioligand therapy, it started in Germany. The first published case, it was in 2015 with PSMA radioligand therapy. It was a case report. After that, with a few months, the German multicenter retrospective analysis was published, and there were many retrospective work and heterogeneous work published from different sites in Germany. After that, we started to see some other cases from other parts of the world. However, the role of PSMA radioligand therapy was only established and accepted in the oncology world, and with our colleagues from oncology colleagues or other also radiation oncology colleagues when Vision trial was published. The same story if we go back to the NITR1 and NITR2 regarding lutetium dotatate in a neuroendocrine tumor. So there is a need to optimize the protocol. There is a need to harmonize the protocol in multi-center trial to answer such questions. However, the most important two aspects that should be addressed is to do dosimetry to anticipate how many grays will be delivered for these metastatic deposits. And the second is to address the tumor residual time. And this can be done by multiple time imaging. So we can anticipate in front how many days or this radio tracer will be concentrated in the metastatic deposits and delivering radiation. And actually, you mentioned, yes, the FAB 286 was the first one maybe used widely. However, there is now some sort of optimization with the albumin binding and some other chemical aspect with the new molecule used by I believe that more than 100 sessions were delivered by Professor Richard Baum, and there is promising data. However, we still wait to see the final publications about the safety profile and about the outcome and the disease control rate of this new molecule.
وزي ما انت قلت يا دكتور أكرم ان الفاب still in its early phases ولسه محتاجين شغل كتير جدا علشان نقدر نوصل لإمتى وفين هيبقى المين جول بتاعه والابليكيشن بتاعته. احنا we are sure is very promising in Theranostics، لكن still مع البيتفولز الكتيرة اللي حضرتك شرحتها في المحاضرة we are sure ان هو still not optimized 100% sure.
Definitely agree. Yes, sure.
مي عندك أي أسئلة تانية؟
We have a question from Dr. Aya. She's asking how is grading the toxicity of theranostic FAPI done? 3 or 4 based on what?
This is the international guidelines for toxicity according to the severity of the side effects. It can be it is graded from grade 1 and grade 2 as mild and grade 3 and grade 4 as severe. And also we use this criteria when we treat with the PSMA radioligand therapy as well as lutetium dotatate radioligand therapy. We use the same criteria, which is the same criteria used by our colleagues from oncology and radiation oncology.
دكتورة مي، ممكن أقول
اه
حاجة؟
اتفضل.
أنا رافع إيدي ومفيش مش عارف أوصل
سوري. اتفضل يا فندم.
دكتور أكرم. very excellent, excellent talk and
Thank
comprehensive
you.
and
Thank you.
insightful. يعني أنا شهادتي مجروحة يعني biased يعني، بس
الله
يعني
يحفظك يا دكتور فادي.
احنا نتشرف بحضرتك. يعني انا هسأل سؤال برضو حضرتك، هل يعني انا ممكن افهم ان مثلا في الدايجنوزس احنا ممكن المايكرو انفايرمنت، يعني الاكسترا سيلولار مايكرو انفايرمنت اوف تيومر، اقدر اي يعني اسمي قربت من التيومر لوكاليزيشن يعني، وده واحد من
صح.
ضمن التاسكات بتاعتنا.
مم.
لكن قربت من التيومر في ثيرابي، دي مش مقبولة خالص يعني انا.
لا دكتور، يعني yes I have a very شكرا على السؤال، طبعا very important حتى زملاء يعني يفهموا كمان. هلا التيومر ستروما it is 90% of the tumor mass and it is responsible for metastasizing, for growth, to confirm and to or maintain the survival of the malignant cell. So the disruption of the tumor stroma is critical to combat cancer. This is very important, okay? And as I mean, we also mentioned that in our systematic review and the publication seminars, that we have the cell-directed therapies, for example, like immunotherapy or targeted treatment like TKIs, but also to target that stroma and the tumor microenvironment is as important as targeting the tumor itself. So if we manage to combine both, this will be a huge progress in our battle against cancer. And this is well proven in many scientific publications. Yes.
Two small questions more. Is there any relation between the SUV max and the aggressiveness of the disease?
Yes, definitely. For example, the most intense FAPI uptake has been seen in solitary fibrous tumors, okay? And this is, as I mentioned, one potential to start theranostic. SUV max may reach above 20 in those tumors. And this also, this has an implication that this is an aggressive tumor and has a great potential to metastasize. And also it has an implication, or it is another sign that those patients would benefit from lutetium, for example, FAPI or FAPI radioligand therapy with minimal activity left to go for the normal organ. Yes, there's
And
strong
also
correlation.
strong recruitment. Also regarding gallium-68, gallium-68 logistically is not an easy issue, very difficult. And also physically wise, gallium-68 energy is 1,900 kilo electron volt. So what is called the positronium bus is relatively long. So the spatial resolution of any radiopharmaceutical using gallium-68 is not the best at all. In comparison, as an example, for the fluorine-18 is 635 kilo electron volt. So the positronium bus is very minimal, 1-2 millimeters, and opposite 1 centimeter in gallium. So have you heard about trials about labeling fluorine-18 minus with FAPI?
Yes, we have the molecule FABI74. It is
Yes.
labeled with the fluorine 18. However, regarding maybe your comment, actually it is very institutional driven. Some institutions, in particular regarding logistic, especially if there is no in-house cyclotron or there is no close cyclotrons in town, okay? Gallium generator, as you know, it can be kept in the department up to 10 months or 11 months. The cost is very reasonable. You can, for example, now I have a generator, I can do 8 to 10 patients daily by gallium, okay? And this is not only for FABI, but now worldwide, if you try to do some analysis regarding BSMA and DOTATOC, you will find that about 80% of PSMA and DOTATOC done by gallium and only 20%. However, if you have in-house cyclotron and you have a good radiochemistry unit and you can use a fluorine, it is possible, and we have a molecule, the molecule FAPI-74, despite the fact that the hepatobiliary excretion, this one has mainly hepatobiliary excretion. The gallium-based, the 46 and 04, mainly renal excretion.
Urinary. Yeah.
Yes. So if we evaluate pancreatic or hepatobiliary cancer, cholangiocarcinoma, we have an issue, and in this time we have to optimize imaging as early as 30 minutes to avoid the hepatobiliary excretion, which will start after 30 minutes in this tracer. So we have both options. Yes.
هو نقاش معاك دكتور أكرم، بس احنا الوقت بتاعنا خلص، فهسأل مي إذا كان في أسئلة تانية قبل ما
في Dr. Gawa asks, in terms of FAPI relative washout, do you have experience in using dynamic PET in FAPI? And another question, is there a value for FAPI in tumor hypoxia?
Yes. Regarding FAPI in tumor hypoxia, no. There are other tracers like FMeso, which can, yes, or other tracer, the FASA also can be used for the hypoxia imaging. Regarding the dynamic image myself, I don't have any experience. As I mentioned, I started conducting research looking at the dual time point, because I used to do 2 time points for FAPI PET-CT scan. I expect to publish our findings in the second quarter of this year. However, I believe that especially in total body PET-CT, and if we have department with certain logistic that would allow for dynamic FAPI PET-CT scan, it will be very beneficial, and many useful information will be generated from such a protocol.
Dr. Ismail raised his hand and he wants to ask a question. أستاذ محمد ممكن تفتح له المايك بعد إذن حضرتك يا دكتور أكرم، تعبين حضرتك.
يس لا بالعكس، الله يحفظك.
مي بعد إذنك يا مي، دكتور عبد الحميد لسه معانا ولا مشي؟
وعليكم.
دكتور عبد الحميد،
معلش، أول حاجة أشكر دكتور أكرم على المحاضرة الجميلة، ربنا يكرمك والله يا دكتور أكرم.
شكرا.
هو بس سؤال سريع، الفابي PET-CT أقدر أستخدمه أعمل بيه assessment of response of treatment؟ لأن المشكلة دي بتقابلنا في الدوتا مثلا أو في PSMA بعد اللوتيشيوم، بيبقى مش عارفين ده هل ده improvement ولا ده ساعات فيه زي يعني.
Very important question. Actually, yes, there is lack of experience about role of FAPI PET-CT scan in monitoring response to treatment. It is specific from a case to case. In certain scenarios, I use it to, especially if the disease was initially depicted by FAPI, I would use FAPI to monitor treatment. However, there are still no criteria, concrete criteria to, like, for example, for recently, just you can see, for example, the BSMA has been for the last 20 years. Only last year we have the research criteria which address this issue, which is sufficient, and we can rely on it. So the same, we need some time, but from personal experience, we can use it in certain scenario with certain precautions, and should be interpreted with cautious and communicate the message very precisely and very specifically to the referring physician.
أكورليت مع الكلينيكال مثلا والماركرز.
أنا معاك يا دكتور وليد لسه.
عايزين نسمع منك
ازاي اسيب الانجويمنت دي.
الله يحفظك يا دكتور، الله يخليك.
والله لا انا ما اقدرش اقول اي كومنت غير انه I'm impressed as usual with the nice and knowledgeable expert دكتور أكرم.
الله يحفظك شهادة نعتز فيها.
الله يحفظك. ودايما المتواضع والسيمبل بيكون مليء.
الله يحفظك يا دكتور.
فأنا I enjoyed this and I learned a lot. And I think we have a breakthrough by using this
Yes.
FAPI, and it will expand, I'm sure, and I'm proud that the Arab world is contributing to this development heavily, and I wish you the best to continue your journey.
Thank you very much دكتور. نفتخر يعني شهادة نفتخر فيها إن شاء الله. تسلم، الله يحفظك. إن شاء الله يقدرنا نقدم دايما.
شرفنا دايما، نتشرف بيك
الله
دايما،
يحفظك سام. الله يخليك.
وكل سنة وانت طيب وعام جديد سعيد
وانتم طيبين
بخير
إن شاء الله. إن
الله
شاء الله نراكم
وشكل.
على خير قريبا إن شاء الله. إن شاء
إن
الله.
شاء
إن
الله
شاء
إن شاء
الله.
الله.
الله يحفظك. تسلم. شكرا شكرا.
share your presentation, your discussions. وسعداء، وإن شاء الله يبقى لنا لقاءات أخرى مع بعض بإذن الله.
إن شاء الله نتشرف دكتور. شكرا شكرا جزيلا.
وعلى
شكرا
الميتنج.
جزيلا.
شكرا جزيلا.
يعطيكم العافية.
شكرا للزملاء.
شكرا للجميع وجهود مباركة إن شاء الله.
شكرا جزيلا دكتور أكرم، شكرا جدا لوقت حضرتك، شكرا جزيلا.
الله يحفظك. أهلا دكتور مي، يعطيك العافية.
آه.
السلام عليكم.
وعليكم
عليكم السلام ورحمة الله وبركاته. مع السلامة. مع السلامة.